In this lecture, we'll begin to discuss some common adolescent diagnoses. I've tried to highlight some of the changes for these disorders between the DSM-4-TR and the DSM-5, and I've also included updated statistical and demographic information that I hope will be more meaningful and relevant for us. When we think about working with teens, we probably think about the trouble that they must have gotten into that brought them to see us. This attitude is indicative of the notion of disruptive behavior disorders. Usually, these are disorders that present challenges for those around the teen. They're likely to begin earlier than adolescence, but they are more apparent now as the teen has increased capacity for aggressive and sexualized behavior. Here I've included a graphic that gives us a snapshot of the prevalence of ADHD in the United States. Disruptive behaviors have long been discussed and classified under the heading of attention deficit and hyperactivity disorder. As you all know, the main issues for individuals with this disorder include short attention spans, difficulties with impulsive behavior, and pervasive restlessness. This is a fairly common presentation. There's some evidence of heritability with ADHD, but there's also evidence that environmental toxins may be related. We know that social factors influence the manifestation of ADHD. If a child has a history of abuse, if there have not been consistent discipline strategies, or if the child's unique learning needs are not met, then ADHD may be suspected. Unfortunately, this diagnosis has been overused, and some believe that medicating children for ADHD is just a substitute for parenting. I finally got my new DSM, so I included a bit here about the differences between the 4TR and the 5. The primary difference that I saw upon first glance was the addition of a severity specifier. Of course, I didn't read all of the text, just a cursory glance. Whenever you think about beginning to work with a teen who presents with symptoms of ADHD, then you'll want to first identify what those symptoms are, how they are problematic, and where they are problematic. Along the way, pay attention to any indicators of depression or anxiety. After you talk with the client, then you may go back and gather additional information from the parents. This conversation will look a lot like the parental interview that we described earlier in the quarter. As you remember, there are certain assessment tools that you are qualified to use and some that are beyond your training. One of the most common assessment tools used with children and adolescents is the Conners. Your degree in education means that you are qualified to administer this set of assessments. I've hyperlinked the web page here. Click on the green text on this slide for further information. ADHD is often seen alongside other psychological difficulties. I can't help but wonder about the impact of cultural factors on the presentation of these issues during childhood and adolescence. I'd be interested in hearing your experiences with ADHD. I have 2 family members that have been diagnosed with the disorder, and I imagine that some of you all have personal experiences too. Many times, treatment for ADHD is reduced to only medication. You've had a class in psychopharmacology, so I won't discuss this in detail, but I did want to offer current information on what pharmaceutical treatments are available for ADHD. If you work with children and adolescents, I would encourage you to become familiar with these drugs. There's also a hyperlink to WebMD for more information. In addition to understanding medications when working with adolescents with ADHD, you should expect to be met with some resistance. Remember, it's the teenager's job to question authority. This includes you. Don't let yourself get sucked into a power struggle. It's not going to help the therapeutic relationship. Pay attention to any indicators of low self-esteem with this client population. Chances are good that these clients have already experienced failures in different areas of functioning. When you are working with teens that have ADHD, it will be important to build a relationship with the parents as well. Set some ground rules before any family sessions you offer, and help family members deconstruct their attitudes and beliefs about their child's struggles. Also, whenever you are working with adolescents that have ADHD, remember that psychostimulants have street value and they are often abused by teens. Be sure that you have an ROI for medication prescribers so that you can collaborate regarding any observations you might have with medication compliance. Finally, remember that there may be several behavior problems associated with ADHD. Be aware that there is some link between ADHD and antisocial personality disorder. In addition to ADHD, the chapter authors discussed oppositional defiant and conduct disorders. Here I've highlighted the differences that I saw between the DSM-4-TR and the DSM-5 regarding these. Again, the differences are subtle and have more to do with how the separate disorders are classified in the manual rather than any qualitative changes in criteria for diagnosis. These disorders often appear before adolescence but can become incredibly problematic during this time as teens begin to experiment with risk-taking behaviors. Locke, the chapter author, stated, "Taken together, a variety of possible pathways lead to a teenager's developing conduct disorder. A genetic vulnerability, compounded by an abusive and neglectful upbringing, with few models for coping with stress other than through violence and substance abuse, combined with a psychological unwillingness to manage these stresses in other ways, converges in the teenager with conduct disorder." Treating teens with severe behavioral problems will require patience, hope, and perseverance. This is not easy work by any stretch. During my music therapy years, I did a rotation at a juvenile facility. I had a group of about 6 guys that I worked with for several months. I'll use stories from this experience next week when we talk about using music with teens, but what I'll say now is that having a plan and having clear boundaries are critical components to treatment success. I appreciate the chapter author's advice regarding low street value drugs. While you're not in a position to prescribe, you will be in a position to work with a prescriber and offer your professional opinions. I would keep this one in mind. There are a number of approaches and strategies that you could use when working with teens with severe behavioral disorders, and these are highlighted here. A lot of the work that you do in different agencies will be prescribed by the agency. I know students that go into different situations and they learn particular behavior modification plans and strategies for working with teens. One thing I would encourage you to do is to pay attention to your surroundings and maintain your own personal boundaries. Dress professionally and conservatively, and don't expect that you will cure anyone. Set realistic goals which will provide opportunities for the clients to experience success.